Hey everybody, welcome back to the Pre-Hospital Paradigm Podcast. I'm Scott Wildenheim. I got Ray Pace over here, and we are live from Kent Fire Department, and with our ongoing series this month on sexual assault, we're welcoming back Dr. Stephanie Gaines down at the end there, and Jen Moreland, who is our sexual assault nurse. And so, first of all, guys, thanks for having us out here. This is awesome. We're having a blast getting out in all the departments, doing these live things, and taking questions from the audience, as well as, of course, the usual thing. Everybody can get on Facebook and YouTube and ask questions real time. But I got some housekeeping stuff we need to take care of first. But beforehand, Chief Samuels, would you like to say a few words about your department and tell the world what Kent Fire is all about?
Yes, thank you very much. We'd like to welcome the UH podcast to Kent Fire. Thank you. My name is Jamie Samuels, and I am the fire chief here at Kent. A little bit about our department. We are a career fire department made up of 36 firefighter medics. We run out of 2 fire stations. We provide fire rescue services, EMS. We have an active USAR team, dive team, hazmat team, and we even have a SWAT medic on the Metro SWAT team. Our primary area that we cover is the city of Kent, but that includes Kent State University's campus, and we are contracted with Franklin Township and Sugar Bush Knolls as well, so we have a pretty big response area. And just to give you an indication of how busy we are, last year we ran about 5,663 calls, so that's pretty big. We have 11-man shifts here with a captain, lieutenant, and 9 firemen. So between the 2 stations, that keeps us pretty busy and active all year round. Mm-hmm. So again, welcome to UH's podcast here at our station. We're grateful that you're here, and I hope we have a good show.
And we have a little thank you for allowing us to come into your house and roll this. It's our
thanks for having us.
Thanks.
It's our UH Pre-Hospital Paradigm Podcast Challenge coin.
Put this in the archives. Thank you.
Display it proudly. Yeah. There's no cash value, by the way. Sorry, it's we couldn't afford that, so you just got the token. But nevertheless, all right. Some housekeeping stuff. The big news.
Yes.
The big news. CE. We now have CE available for all of the previous episodes, as well as all of the upcoming episodes. So that is currently Ohio EMS continuing education only, and you can go prehospitalparadigm.com. It's our usual website. Not only will you find links, they put them up live today for all of the CE product and registering for that. That's a free one year gig. We will have some other products available for CAPCE accredited stuff, hopefully into end of the year, beginning of next year, stuff that you can apply for like National Registry and National, so we can offer this outside of the state of Ohio. That's up and coming. That's a big lift, and we're still working on that. But again, all the episodes right now, you can go on, get registered, get that Ohio credit. Again, prehospitalparadigm.com. Not only will you find that, of course, you'll find all the show notes for this and all of the other shows. There's a whole series on there for great cases. There's all the Pharmacy Friday repository. Anything that we put out in the world in the EMS space as far as free open access medical education, it's all in that one place. So hop in there and check us out. Big help if anybody would hop over on YouTube. Our big push for the remainder of the year is YouTube subscription. We're putting out a ton of content, and if anybody can pop over, hit the subscribe button in YouTube, that would be fantastic. All of this today is being brought to you by FirstNet and Cradlepoint. FirstNet, the AT&T First Responders Network. This entire thing, every bit of data that's streaming out of here is leaving our kit over here, going out on the FirstNet network, and all of that is being streamed through the Cradlepoint hardware. So big thanks to them. They sent all of that free to us, and they've also got a special offer for you. If anybody's not already on FirstNet, prehospitalparadigm.com/FirstNet, and then there is a discount code on there for a FirstNet service if you're not already on it. Oh boy, I got a whole laundry list of stuff that I had to get through there. I think I got it first, and then this recording, this release of this recording, and this live was intentionally coincided with April being Sexual Assault Awareness Month. Mm-hmm. So that's why Jen has given us all of the ribbons here. So we thank you for bringing that. Either you want to speak a little bit about what all goes on during the Awareness Month and some stuff that maybe you've participated in?
Mm-hmm. So for the Awareness Month, we do different events. Our favorite event to do is table events at all the community hospitals and at main campus, where we set up a table and we give out ribbons and snacks, and people come up to the table and they talk to us. It's wild, like in a good way, what people share at the table. That it's just, it's nice for them to be able to unload, and it's nice for us to know that like the need for us in the community is very great. So we do that. We call that table. We have like a big wheel with a game, and there's like you spin the wheel and what would you do? And then it opens up this whole can of discussion.
Oh, nice.
Which is nice.
It's just a safe space for them to approach you, talk, and promote everything that your program offers. Is probably
raise that awareness.
Raise more awareness to the community.
Yeah, we let them all know that if anyone they know has been sexually assaulted or victim of domestic violence or human trafficking, that they can come to any community emergency department and we can provide services for them.
So
yeah, it's really wild, like how you'd be so surprised, like how many people just want to share their stories, tell you about their loved one, their child, their life experience. It's really wild how many people just want to open up to you, like in like 2 minutes of meeting them. So yeah, it's really great having these events, these community awareness events. And then if you hadn't figured it out, teal is the color for sexual assault awareness.
And I got to imagine that interact. I mean, first of all, we're dealing with a very heavy subject here, right? And it's to be quite honest with you, when we did that initial recording, I don't know about you, but I came in there and I was just like, I don't know how this is going to go, right? This is going to be, it's a heavy subject. So to have those outlets and whatnot, and actually see a kind of a brighter side of it, I imagine that's very rewarding for you all, right? You're not just kind of in the trenches and just seeing that on the back end, the clinical perspective of that, right?
Yeah, absolutely. Because it came up in the podcast. It's an uncomfortable subject, right? And so it's uncomfortable to talk about it, almost taboo, so to speak. But it's like, it's amazing how many people just want to open up and talk about it, because it's such a common phenomenon that occurs, unfortunately, and so people just want to share their experiences.
That's awesome.
If you think statistically, 1 in 5 women sexually assaulted, just to go 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, the people coming past our table.
20%,
Yeah.
That's hard to believe.
Yeah, that's a crazy cross section when you really think about it. So. Just a little recap, and then we got a few other things that just high points we want to hit, and hopefully we'll get some of the questions that came out of your presentation that led into this, and we'll look here in just a second, see if there's anything coming in on the internet. But just talk a little bit about your roles, as the medical director of the program, and then what the nurse examiner does. Just they've heard a little bit about that, but maybe somebody is watching just this live. We popped up in their feed, and maybe you can tease them to go back and watch the entirety of the episode. But just a quick little recap on each of your roles.
Yeah.
In this space.
For sure. So I am Stephanie Gaines. I'm an emergency medicine physician. I work at UH Main campus as well as UH Portage in the ED, and I serve as the medical director for our sexual assault forensics program, which mostly was at main campus, but over the last few years, we've been training a lot of nurses and expanding services to make this a system-wide program. And my role as the medical director is to kind of provide oversight, to provide kind of a quality assurance, peer review, medical direction for the SANE program, and things of that nature. So that's kind of my role as the medical director.
That's awesome. And then you got the heavy lift here, right?
So I'm the SANE lead for the Southeast region with UH Hospitals. I cover downtown main campus, and then I train nurses. I have an office at Portage now in Ravenna. We have 24/7 coverage there now, so nobody has to be shipped out. Woo.
Excellent.
It's awesome.
Right.
And then Geauga is the next hospital we're going to start working on, and then Conneaut and Geneva. Like it's so, just trying to train our way up. But I do cases for sexual assault, domestic violence, and human trafficking. I provide education to nurses that we're training to do these cases. And then I also do a lot of community work with, a lot of the communities have sexual assault response teams. So like Portage County has a sexual assault response team. Geauga County has a sexual assault response team. So I go to their meetings and I meet people that have resources for these victims in the community, which is really nice. And then I work with law enforcement as well, providing like education on all the things that we cover.
Talk a little bit about the rest of the system. So, I mean, you said you're working on 24-hour coverage in some of these places. We have it here in Portage County, which is awesome. I guess let's take the EMS side of this. Is how do we know, right? So, okay, you just let the cat out of the bag. These guys have it, these guys have it easy. Let's just say, another department way out, not even part of our medical control, is transporting a sexual assault, domestic violence. What do we need to do to prepare the hospital to make sure, or as far as hospital choice?
The squads
as part of that
sometimes the
part of that
squads will
transfer.
call in.
Yeah.
Do you have a SANE on staff or a SANE that will be available?
All right, so just straight up ask.
Right, but Portage and main campus have 100%. There's going to be someone there to do a case.
And in the let's take other traumatic injury or any other injury off. It was a sexual assault, but the patient is otherwise stable. Is this somebody that we should divert, go to a different hospital, bypass hospitals to get him to specialty care, or is this somebody that goes to the closest facility and then transport gets arranged on the backside? What's the better play there, or is that totally situational?
I mean, of course, it's going to be situational,
Sure.
but I think ideally, if you kind of know that it's not someone that's going to need like a trauma center, for example.
It's not a trauma alert.
But, someone who is going to benefit from seeing a forensic nurse and wants to see the forensic nurse, then it would probably be best to transport them to a facility that has a SANE nurse on call, or that can provide the response to that patient.
I guess that
answers the question. Yeah, because I think that's one of the biggest things that comes up in EMS, and I know I've been here before and we've talked about it, and our approach is always to take the right patient to the right place at the right time. We take a trauma patient to a trauma center. We take someone that's having a STEMI to a PCI lab.
Sure.
So maybe not in Kent, but it didn't take too long when we got our first call in the city here.
Is the call counter up? No, okay. The call counter is going to pop up on the feed.
I think one of the things that our approach is if you have maybe even a northern Portage squad that had that decision, do I transport to Geauga or do I transport to Portage? That would be a question we would want them to ask, or at least give them the outlet to make the proper choice. They're both level 3 trauma centers. But if, let's say, Geauga didn't have coverage, even though I know you're building it in the community, but if Portage had that resource, if we're going to drive 8 minutes, the other way, but that's going to give the patient the best care at that facility, then that's the most appropriate. And I think that's one of the biggest questions that come up to us are, do I transport that patient to the facility that has the correct resources? Yes, it might be a little bit longer, but that's the most appropriate. And we all know once you get a patient into the system, and then you have to get an accepting physician at the other facility and then transfer, and that just takes a lot of time, and it's already a stressful situation. So if we can decrease that stress and just transport the patient to the appropriate center, And that might just make, we might have to make a couple phone calls, I guess would be my big point there, but
Yeah,
nothing wrong with that.
But
That's
yeah.
what's best for the patient.
I think that's exactly it, right? Like, UH has SANE coverage, period, right? But let's say like a patient goes to Geauga, for example, and there's not a SANE nurse that can go out to Geauga, right? Then that patient who already undergone a very stressful, traumatic situation, sees one ED provider, then, is there for a handful of hours, then
right.
potentially has to
Yes.
get transferred, God forbid, to main campus, which is like the big, oh my gosh, big scary downtown place, which
Yeah.
no one wants to go to, from their small community
From their community
site.
hospital, sure, right.
Yeah.
Yeah.
Or,
Night and day
maybe they
difference.
get transferred to Portage, but, it's just not an ideal situation. So being mindful and thinking a couple of steps ahead, like if that patient is, not going to need anything acute and is stable and can be, and really, can be transported
Right,
to where the
right.
SANE nurse is, that's kind of going to be the best situation for the patient. So,
And as your program continues to build even more, you're going to have more and more resources available in a lot of the community hospitals in other counties that you've even mentioned. So
Yeah.
that's great.
Yeah, that's huge.
And like you said, situational. So if the assault happened outside the window of the time for a kit, then it wouldn't matter what ED they went to. They can get the sexually transmitted infectious disease prophylaxis medications and Plan B at any of the community hospitals.
Talk about that window.
Yeah, let's talk
It's
about it.
96 hours
Okay.
post-assault.
Yeah. 96 hours.
for evidence collection,
For evidence collection, yeah.
to get a kit done.
Okay.
Yeah.
Okay.
It's 72 hours to get the NPEP if you feel you might have been exposed to HIV,
Okay.
or the risks were there.
Okay.
And then it's 96 hours also for the STI prophylaxis medication.
Gotcha.
Yeah.
How do we, some of these cases are easily identifiable, right? What about some of these edge cases that are hard to determine? How much time should we spend trying to figure the situation out and play detective on these cases? Is that,
I would say minimal,
yeah.
because the medical is the priority.
Yeah.
And then we'll figure it out wherever they end up.
Yeah, obviously the leading question, because that was the big thing that
Yeah, that
Ray
came
and
out
I
of the
were talking
podcast.
about, that our clinical treatment trumps all the other things. I think we talked right before we did the recording, the in-studio recording. There was we were talking about a situation where there was a department that had a patient, and they spent their entire time trying to preserve evidence and preserve scene and do all these things to the loss of thorough patient care, right?
Yeah.
And that came up multiple times in the recording, and I wanted to make sure that got out there for the live audience, is that our clinical care comes first. That is our job, not
Right.
being a detective, not necessarily preserving evidence. Another thing that you guys said that certainly resonated with me was revolved around our action and what we do is not going to make or break the case.
Yes.
Right.
So true.
Yeah.
I mean, we are medical personnel.
Correct.
That is our job.
Yep.
It is so tempting to want to be investigator and detective and play those
Right,
roles,
right.
right? And try to figure it out and piece the puzzles together.
Yeah.
But that's not our job. That's not our role. And so, the medical care is our priority. Even though we might be tempted to try to sort it out, we are not the detective. It's not our job to sort that stuff out. So, and we can't mess it up. We can't mess up the evidence and all this other kind of stuff. Like, again, that's not our role. So just getting rid of that fear.
That's,
Yeah, I think that was a large part of it.
That's a big-
and I don't want to speak for the audience, but I'm sure some questions are going to come out of this. And I feel like this is a topic we talk about, and then when we were in studio and did all the recordings, we as EMS are so hesitant to even touch that patient
Right.
because it is an uncomfortable topic. It is kind of taboo, as you put it.
Yeah.
We don't want to ruin anything.
We don't wanna
we
ruin
just-
it, yep.
We just want to wrap the patient up in a sheet and take them to the hospital. And I think by doing this podcast and watching some of the recordings, I think it could really open a lot of providers' eyes that this is a medical patient that could have medical problems that we need to truthfully do a good assessment on, or this could be a trauma patient.
Medical, trauma, psychological. It's
just all of those different topics, and we want to treat the patient first. Yes, preserve evidence, but I think you hit the nail on the head there. Is we're not going to mess anything up. We're not going to ruin any of the evidence unless we do something blatantly just, dumb, for lack of a better word. We're not going to do anything wrong. And I think compassion goes a long way, but a good patient assessment, whether it's a medical patient, a trauma patient, maybe they just need some empathy, support in their time of this, mental trauma that they're dealing with. And I think that's good for us to know too in EMS, because we're just, like I said on the recording, I was like, I don't even want to say it. It's just like, I don't want to do anything wrong. I don't want to, excuse me, I don't want to do anything wrong to this patient.
Right.
So I think that was such a huge icebreaker of conversation with all of us.
Yeah, the concern is we're going to somehow skew all that.
Correct.
That we're going to skew that view, and it's not the case.
So these victims might, because they feel safe with you guys, they might say what happened to them. They might divulge that to you guys over law enforcement, because that trust from just your being kind, providing that trauma-informed care. Very simple. Are you okay? And it might just come out, and then that might guide after they're medically cleared, that might guide your plan for them.
Sure.
Treatment-wise.
And then I think
Of
the
course,
other.
go ahead.
Sorry, go ahead.
You were going to say it. Go ahead.
I think that opens the window to them opening up to us. And then the other thing too that we hit, that I know is one of our bullet points and talking points, is we may be the only ones that were actually in the scene, in their room, and be able to get a good observation. And I know in our organization we really worry about scene times, how long we stay somewhere, and this is a different situation where whatever we might observe might be key to pass on to law enforcement, pass on to the hospital, and then also document on our run report as well, which could be beneficial.
Yes.
Yeah, that was the bullet point, was documentation. Anything that either you can recommend specifically to us that we should be putting in our narrative, bolstering, care, scene, and anything like that.
I'll tell you what not to put in it.
That is just as good.
important.
I think we all respond to what not to do just as well as.
Alleged sexual assault. Don't put alleged. That's horrible.
Would it just be better to say like patient
Reported.
stated, and then put it in parentheses?
Patient
Yes.
reports, and then
Patient stated,
use a
and
lot
then
of
insert
quotes.
whatever they tell you. Is that a safer bet? And then that's just an easier way to document it?
Yeah,
Okay.
absolutely. You really want to, keep your biases in your head, I guess. You kind of want to check your biases. And I don't know why we do this, but we always, it's always reported sexual assault, reported, alleged assault. I don't know why it's in the EMR like that, but it is. And it's like, we don't say alleged abdominal pain, alleged headache.
Right.
You know what I mean?
Yeah.
Like, chief complaint is headache.
Is the headache,
The
right.
patient has a headache. Chief complaint is assault. They were assaulted,
What? So we hit the what to say, kind of not what. Well, let's go back. Any other things that we should that we should say that is impactful and helpful and meaningful to this population?
Yeah. I mean, I just think one of the most powerful things you guys have the benefit of like being on the scene. Seeing what's going on in real time, before the patient comes to the emergency department. I'm kind of like shielded by four walls. This is my little box, and having the patient already removed from that environment. But you have the, I guess, benefit of seeing like
seeing the whole thing.
Yeah, seeing the whole thing. What was going on in real time when it was like a very critical situation, and the patient is there, and maybe the assailant or perpetrator is there. What did that environment look like? What did that scene look like? Looking at children in the home, what did they look like? What do the children have to say? Did they utter anything? So utterances that you don't particularly, ask, a patient or people that are there, but you can document things that you say in your report, which over time, depending on what's going to happen after the fact, can be very beneficial to the patient, And I think statistic-wise, it takes about, on average 7 times.
7 times.
7+ times for, a patient who has undergone, violence and assaults over and over before they actually leave that situation. And so being able to document what you hear or providing all those details in your report is very helpful for the patient, especially in the long run.
So not only not only document what you specifically ask of them and how they respond, but any spontaneous offerings as well,
Yes.
right?
Yes.
Okay.
Absolutely.
How about are there any telltale signs? I mean, if we just get called for, I fell down the steps, right? Fell down the steps, or some other innocuous thing, right? Is there anything that we should be now? I would imagine most everybody in this room has been doing it long enough. You get that sixth sense. You walk in, and it's like,
Your
all right,
gut.
this is off,
Absolutely.
right? This is
Absolutely.
off.
That
You have that-
intestinal,
Yeah.
something's
You have
not
that
right.
unsettling feeling that
Yeah.
the story just doesn't make sense.
No, it's not. It doesn't add up. But other than that, I mean, that's hard to, and certainly that's hard to sell to a junior provider, right?
Sure.
To somebody that's new to EMS, right? New to healthcare, right? That's not even unique to us, right? How about you walk in a room that's new to the hospital, new to EMS, right? New to healthcare, but. Are there any other tangible things that we should be looking for?
The gut aside,
Okay.
the gut's important.
I totally agree.
Spidey sense for sure.
Yes. But the response I was talking about, the freeze, flight, fight, fawn, or flop, everybody responds to trauma differently. And it's not like you're choosing to respond that way. It's like an instinctual survival thing, and who knows how the body's going to respond. So you might have someone that's not being particularly cooperative, and they're out of their minds. It might appear that they're like on drugs, or there's something else. And that's where the trauma-informed care comes in, because who knows what you might find out.
Right.
Just being kind to them and understanding that this might be a response to trauma.
So having a lot of patience with these patients, I think you can't cast judgment to be like, oh, well, this patient's acting very odd for X, Y, and Z to supposedly just have happened to them. You know what I mean? But like Jen said, everyone responds to trauma differently. And so, when someone's in an uncomfortable situation, they might laugh hysterically. And you're like, wow, that's really odd that you're doing that when you just got the snot kicked out of you. But that might be a normal, natural trauma response.
For that person, and
completely.
They're all going to be different, and that's kind of hard to read. And maybe just take some more time on your assessment to try to understand.
Yeah.
Versus getting tunnel vision and then just putting that patient into a category, for lack of a better word.
You downplay it because this doesn't match what I believe.
Correct.
Odd,
Should be the response to this situation, or what I think my response would be to this situation.
Right.
Or what is normal, perceived as normal, because
perceived normal,
really there's no normal response to it, and everyone's going to react differently. So I think we just have to be very open-minded, trust your gut, and maybe ask the appropriate questions in the appropriate manner.
Yes, absolutely, right? So, what are some signs that, that was kind of your question, right? Like, are there inconsistencies, injury patterns that don't really make sense for what the patient is telling you? Like, oh, I fell down the steps, but then why do you have all of these bruises in various stages of healing?
Like the defensive wounds.
Right.
Yeah, and then like noticing things like maybe the assailant or other partner is very controlling and trying to control the situation, you know what I mean? Like, things like that kind of just put up like red flags to say, okay, something is off here, something is not adding up, something isn't right. So things like that might heighten your awareness for, something being off or a suspicious situation.
Yeah, maybe the partner is trying to answer for the patient when we really want the answer from the patient, and then that might need to trigger a response in our head. But let's take you to the ambulance and check you out.
Yes.
Like why don't we go there, and then we can maybe naturally separate the patient from maybe their partner that's trying to speak for them, and then we might get that true story or see more bruises, or at least try to understand a little bit more of the situation. And these are tricky to navigate in our world, and PD is typically present. Law enforcement, so it can be kind of unsettling sometimes on these scenes, I think, for all of us treating these patients.
But then what do you do when you suspect something is awry? Like, how do you guys handle that situation? Like, if your spidey senses are tingling and you're like, something is just not right. I mean, how do you react in that situation? Does it change your interaction with the patient? Does it change the type of questions you're asking them?
I certainly believe it drives, my line of questioning, but to Ray's point, it's first we're going to start splitting people up,
Yes.
figure out a way to, drive so I can get individualized, compartmentalized stories, and then start that natural comparison that
Yeah.
as healthcare providers we instinctively do, right? It's like,
Right.
things aren't adding up, right? Certainly in my mind, that's where I
Yeah, my head's in the same place. I think that I don't believe that we change our approach at all. I think we appear completely normal to the untrained eye. But I think if you've worked with someone long enough, I think your partner,
Subtle tells.
your partner
Yeah.
is going to understand what you're
Subtle
doing.
tells.
And like the first thing that we would try to do is probably separate them. Naturally, make it look normal. We got to take you out to the ambulance. We have to do more of an assessment, or we have to put you on the heart monitor. I'm going to make something up
Right.
that sounds legit.
I think your heart feels a little irregular. Let's go
And
check
then
that out.
I feel that a lot of times that you get that patient in the ambulance, and then that might be the position where they open up. Is can we just run through your story one more time? I'm just trying to understand this. Is there anything else you want to add? Is there anything else that you left out? I think you just kind of open the door to see what the patient's willing to give in that time, depending on where their mental state is at. And we're just trying to gather whatever they want to give. You don't want to force it, and I don't believe we really change our approach, but if we could get them in a calm environment, maybe get them out of that environment that was just, tragic trauma to them, and put them in our world, then a lot of times maybe we'll get that response out of that patient. Maybe they feel safer in the ambulance.
Yeah, for sure.
Conversely, how often do we bring you somebody that we're clearly suspicious of, and they don't want any involvement or intervention or examination from your team? Is that a common occurrence, or have they been kind of almost gone through a few layers of vetting before they get to you, and basically who you're called for, you get to
It depends.
you get to evaluate?
It depends on that individual, because there are people for various reasons
Sure.
that don't want to share that they were sexually assaulted, possibly because of who the assailant is, a boss, teacher. They don't want to get that person in trouble.
Sure.
And like I said, with like the college age kids, they don't want to mess up their social life, and that's a friend of their friend. So there's lots of reasons why people would decline.
But I think too, also, like, after so many points of contact, and this person on the scene, their suspicion, then they get into a private situation where they go into the back of the ambulance, then that's another touch point where someone's asking them these questions, and then they get to the hospital, and I don't know, maybe the resident goes in, and then maybe the attending goes in, and it's all an opportunity to kind of allow the patient time to kind of process what's going on and give them an opportunity to divulge what really happened to them. And I think sometimes it's okay when your suspicion is so high and the story's not adding up, it's okay to ask in a respectful way those direct questions.
blank, yeah.
Yeah, like, did someone hit you? Did someone try to hurt you? And maybe they don't want to be open and, rattle off X, Y, and Z and tell you the whole story, but that's a simple yes or no answer, right? And if they say yes, okay, now we've moved a couple of steps ahead, and you can ask them more questions from there. But
It just might take time.
It just might take time.
Make them feel comfortable, make them feel safe, make the patients feel safe, and then see, they'll be, as they become more comfortable maybe throughout that process, or those opportunities, whether it's with us, EMS, or in the emergency department, when they get to a point of comfortability, then they're more likely to hopefully open up. And then, we as a team, we could help them, whether it's in the emergency room or the pre-hospital setting. I think that's huge.
yeah.
So with that trauma response, the chemicals and the endorphins and all the things going on in the brain, like I said, the police officers, if they're involved in a shooting, they have to do 3 nights of sleep before they do their report.
That's nuts.
And person, you were just assaulted, and I want to know what happened.
And I'm here
I want
10
you to
minutes
tell
later.
me right
Yeah.
now what happened.
Right.
Yeah.
And you need to make a decision.
Spill beans. Right,
Do you
yeah.
want this? Do you want this? Do you want this? And
Yeah.
it's like, but I think just letting them have time to process, because they still are trying to organize the assault. Like especially like drug facilitated sexual assaults. They are foggy headed.
Oh, sure.
So between the trauma of that, they're not for sure what happened, but they know something bad happened. So then we're expecting them to make decisions. So
Yeah.
we give them time.
And with drug facilitated, it's crazy. Like patients will come in and they've lost an entire day where they don't know what happened, but they know something happened, but they just can't piece it together. But they know something bad happened to them, but they, have no recollection or completely amnestic to the events.
And that's when it's helpful on the scene if like a friend was like, this guy was creeping on her all night
Yeah,
long.
yeah. Start
So,
piecing
then
things
she's
together.
telling her like, something bad happened. We didn't see you guys for a while.
Yeah.
What percentage of all of your cases have some drug-induced piece of that, drug-facilitated piece of that? And just not a hard
Well,
statistic,
well-
just a guess. I mean,
Well, a lot of the cases involve just the person being intoxicated.
Sure. Yeah.
If you're drunk and you're passed out, you cannot give consent. Like you consume that alcohol on your own. Nobody put anything in it.
Right.
That's rape still, even though you're wasted. But then there are, I don't know the exact percent. I would say it's a small percent where they were actually drugged. Like actually somebody put something in their drink.
yeah.
Okay.
But I hear
To stop them.
stories all the time, though, of people who have suspected it. And I don't know the percentage. I don't know how you really prove that.
I know it's hard. It's a hard because there's
It's
But
all
I hear
under- it's all
stories
under
all
re-
the
it's
time,
all
especially like
underreported.
from college.
the college-age kids.
Yeah.
Yeah.
It's all underreported, but I bet that subset is
Even more underreported.
far more underreported because
I would say
you have no recollection.
You have no
can't piece it
recollection,
together, yeah.
and then a lot of times people blame themselves, right?
Of course.
Like, oh,
The
I shouldn't
guilt.
have went out. I shouldn't have
Yeah.
drank too. You know,
I let
it's-
myself get in this
Yeah.
position. right?
Exactly.
Yeah.
Yeah.
Right. So of course they don't say anything. They don't investigate, or they're embarrassed.
Questions?
Yeah, well, yeah. Anybody out there have any questions for Tim's keyed up? He's
Yeah.
got some.
Evening. I have two questions, and then I'll pass the mic. Could you speak to what happens with the kit once it's collected? Does it go to local law enforcement? What's the chain of custody? How long is it good for? Just speak to that. And then my second question is, you said that you offered victims Plan B. Is there any threat of losing that with what's going on at the federal and state level with abortion laws?
I'll answer the first part. You answer the second part.
She's like, I don't touch that second part.
So the kits. Once the kits are done, the paperwork's in the kit and we seal it. Law enforcement comes to the bedside typically, and it's nice because a lot of law enforcement will come and they will get a report from the victim, and then they'll take the kit from us. I sign that I sealed the kit, I sign that I released the kit, the officer signs that they took the kit. And from there, the officer takes it to the medical examiner's office, whether it be BCI or what county coroner, wherever they take it, and they sign it. So there's a full chain of custody. But something really cool, within the last probably 10 years, the Ohio Attorney General has set up on their website, you can track your kit. Because of 10 years ago when they found these warehouses in both Cleveland and Akron full of kits that were not processed, these victims didn't know, anything. So what the victim can do, they can log into the Ohio Attorney General site and see that it went from UH Portage Hospital, picked up by the Portage County Sheriff's Department. Sheriff's Department, when they go in, they log it to the BCI. So the victim can see that their kit's being moved and processed. Now they can't see any results of anything on their kit. The only way that they'll know that there's a hit biologics on that is if the prosecutor contacts them and they move forward with the case. Otherwise, they don't know if there's any touch DNA or anything in the kit.
And obviously, that's all de-identified. They're given some sort of randomized number or
Yes,
something to the
yeah.
kit. So
Protected.
Yep.
yeah, it's
And so I guess I have the pleasure of answering part 2 of the question. So not that I've heard, to my knowledge, UH hasn't placed any restrictions on us offering Plan B type of medications. And, the idea, I guess it's similar to birth control, right? You're kind of taking, Plan B within a certain window of time after sexual intercourse to try to prevent, inception. And so, to my knowledge, there's no like legal ramifications in terms of offering like Plan B contraceptive medication.
Another question?
Anybody else?
Yeah, you talked in your presentation about the 5 different things, and FLOP was one, and in that was seizures. We see in this community a lot of things that are named pseudo-seizures and not actual seizure activity. Should we be looking at those in a different light, or do we need to, I guess, combine or activate more SANE protocols versus community paramedicine protocols to assist in those people's care?
So are you saying like you get called to a scene because someone's actively seizing?
These particular patients that I'm talking about, yes, they do. They look like they're seizing, but medically they aren't seizing in the brain. It's more of a dynamic of psychology or psychological stuff. So I guess my question is, do we need to take a different approach to these patients and activate your group, or look into more the background of what's causing them?
So I would say if your gut is telling you something's not right, and there are signs or symptoms of something nefarious happening, then certainly we would be included. But people could be doing that for lots of reasons.
So it's hard.
Yeah, it's a hard one.
That's a hard
tough
judgment
one.
call.
So I guess it depends on the situation, right? Like, I guess if it's a person who has a history of pseudo-seizures, and a lot of times pseudo-seizures can be stress-induced, but I guess it depends on when you guys get called out to the scene, what is the situation at the scene? Is this some kind of, party where alcohol and drugs were involved, and maybe there's some suspicious characters around the patient, then maybe you might have a heightened sense that, a sexual assault occurred or something of that capacity. But I guess it depends on what the situation is, yeah. A good question.
Obviously, being a college town and being in EMS in here, a few of us here for a few decades, we get quite a bit of these type of calls. The one thing I think that I've seen through the years is that we feel like we need to have an extra person in the back with us. And I understood for most of my career, I think that was more of a protective thing. So I had one case where it was definitely, you could tell it was not welcome, that any more than one male in the back was going to be problematic. So I guess just to hear from your perspective, do you think that's something that we should work towards, or is it just a case-by-case basis? And I had just one follow-up after that, after you answer that.
I would say case by case, because everybody's response is different.
Yeah,
Okay.
I would agree with that.
So I guess I think the worry for us is liability. Is something going to happen in the back that, I guess has there been cases in the past where something has been said about a police officer or a paramedic?
Are we going to be accused?
Yeah, are we going to be accused of something? So I think that's the worry.
I mean, I think, well, we've cared for patients that have said, like, oh, the EMT provider had his, crotch too close to my face, or whatever, rubbed up against me in an uncomfortable manner. So, yeah, it can happen, but it also can happen in the medical, setting as well. You always, are fearful of that liability piece of it, but I think it has to be a balance of, what the patient seems comfortable with, and you'll have that, I guess, sense, right? Like I had a patient that I took care of yesterday that, she needed a pelvic exam because she was concerned about STIs. And legally, you are supposed to offer the patient if they want a chaperone or not, and they can decline a chaperone, and then you can proceed with the pelvic exam. But in this situation, the patient was just a little bit odd, and I kind of felt uncomfortable, and I kind of felt like, you know what, I'm going to have the nurse come in as a chaperone while I do this pelvic exam, because I just want someone there to kind of vouch for me, that there's no funny activity going on in case, she gets the wrong idea. So I think it's situational, and then it's trying to find that balance of what's the patient comfortable with, or you're gonna kind of know based on your what your gut is telling you.
And then lastly, I think the one thing I'd like to share, critical incident stress is huge, and we always think about the big, pediatrics and maybe, obviously fellow firefighters, those being the big hot points. But I'll be one of the most recent critical incidents to me was dealing with a pretty violent sexual abuse. It was over hours. She opened up to me in the back of the squad and was very angry, but wanted to tell somebody. Yeah. And I was actually surprised on how it affected me. Not just the next day. You get mad, you get, especially being a dad of a daughter, but it affected me a few days and a few shifts, and it was something it surprised me that it was that impactful comparative to everything else that you think we see. So I just want to throw that out to everybody, that I think that's just something to share and to let people know that, you're not alone if you feel that way, because I think, it all catches us at different points in our life, and so thank you for bringing this up.
Absolutely.
Yeah, vicarious trauma it affects everything in your life. It affects your friendships, your relationships, it affects your creativity, it affects your focus, and you may not, like you experience and see horrible things all the time,
right,
and you may not realize that trauma is impacting you the way that it is. Because it could be like a gradual thing, especially if you've done it for years of vicarious trauma, absorbing people's trauma, and that's why self-care is so important. It's important to talk about it. We share cases all the time, and it's like it kind of like unloads, and it's nice to hear other people share that they have felt the same way. But it does impact every piece of your life. The creativity on the brain is where, I noticed it for me. On I lack sometimes creativity. Sometimes I normally have. Sometimes people get cold. They get cold to emotion, and that's just a defense mechanism to handle the vicarious trauma. But it's very helpful to do kind of like peer reviews where you talk about the cases and how you felt.
Absolutely.
My question is kind of twofold. You said that in Portage, the Town Hall 2 is your advocates. Do they follow the patient's mental health, and are those mental health care providers specialized in that kind of trauma?
Yes. Yeah. So when the advocate comes, they sit by the patient, and they, like I said, provide blankets or Kleenex to hold the hand or whatever that person might need. And then when the case is done and the police are done and the person's being discharged, they'll get all the information, all their contact information, and then they'll call them in a couple of days and follow up and offer various kinds of resources for counseling and group sessions, like individual sessions, and they follow them all the way through.
It's a great resource in Portage County.
Did Dr. Hill put you on the spot?
Yeah, I guess.
Yeah, all right.
So I guess I just kind of have a question. When dealing with patients that we go on a call for that's unrelated, and they come up and open up to us that they've been sexually assaulted, when are we notifying? Are we supposed to notify law enforcement at this time, or are we going to notify the hospital and that'll be conducted that way? So we're not going to have to notify law enforcement. And if we're on scene with law enforcement, semi-unrelated or completely unrelated, are we supposed to notify the law enforcement there of what we're being told?
I would say yes. Just because that way they can start the case.
You're saying notifying law enforcement if they're on
Yes,
scene?
yes, 'cause they're on
Or as
scene.
soon as you hear it, notify law enforcement?
Yes.
Do you guys have protocol? Like, do you guys have protocols on this? I mean, because it's mandated reporting.
Right.
It is mandated
Right.
reporting, and I think it's a good question. I think if law enforcement is present, I think our go-to would be to tell them on scene. I
Right.
think it's we put them in the back of the ambulance, and now we're moving to the hospital, and then that just comes out now where
Yeah.
it wasn't suspected,
Yeah.
you had no gut feeling on it.
You're working
and then it
backwards
just,
at that point.
You're,
Right.
Yeah,
You're
I
working
think
backwards.
I think it kind of forces you to work backwards then. Because we're kind of in the in-between stage. We're driving to the hospital, so it's like, do we report? We know we're mandatory reporters. Do we report at the hospital, or do I need to notify PD while I'm en route to the hospital? I think that's kind of the gray area you're kind of
Yeah,
describing.
right,
so,
right, right.
so I think as long as you mandatorily report, I think you're fine. I think if you're in that transport mode and you go to the hospital where that law enforcement officer isn't present, then you can tell the hospital, and you can also make the call probably back to your officer, or follow your chain of command here. But it's also still appropriate to notify Kent PD, because if it occurred in Kent, then Kent PD is going to end up being involved in it. Do you agree?
Yes.
Yeah, and
Yeah,
the
I think
CYA there is your documentation, right?
Correct.
Exactly.
We were halfway to the hospital
Correct.
before this came out. Approximately this time, this was stated.
Yes.
We started these processes after the fact, right? So maybe we didn't call and say, "Hey, we have a potential SANE case here." We're walking in the door. It's the same thing. Hey, they just disclosed.
Right.
Sorry, we're a little behind the 8 ball, but
It's better to
And that happens.
over-report.
Yeah, right, yeah,
That way they can
exactly.
say, yeah, we know.
Yeah.
That's the way I kind of view it.
Yes.
As like tell both. If you're that close to the hospital, get to the hospital, tell the hospital, and then I can make a phone call to the PD, and then the worst case, one of your officers has to go to the hospital. Which is not a big deal. That's normal for a lot of things.
Yeah.
one of the things, since we're talking about law enforcement, is have this dialogue with them ahead of time, right?
Yes.
And you spoke to that extensively on the recorded version about, hey, we got to have these interactions with our law enforcement ahead of time and
Correct.
understand the expectations on both sides, right? They need to understand, hey, our clinical treatment's going to come first, even if they're trying to preserve evidence and things like that. But conversely,
Yeah. No, I think that's huge. You have to have a good relationship with your PD all the way around. It's one team, and in our organization, our police department eats dinner a lot of times with our shift. And that's where a lot of those conversations come up.
Yeah.
Is hey, I had this call. How did this work? Or they ask us a lot of questions too. So I think building that good relationship between FD and PD helps a lot as well.
And shout out to UH Portage PD. I feel like they are just a wonderful department, and a lot of times they are, sitting in the emergency department, very close, interacting with patients and staff. And so, like, if it's a situation where, you're kind of working backwards and the patient discloses in the back of the rig, when you get to the hospital, I feel like, even disclosing to UHPD, and they could kind of take it from
They can
there
help
as
assist.
well.
Start
yeah.
with that. Start
No,
the
that's a good point.
Yeah.
The other takeaway that just I wasn't prepared for until you all started talking and the recorded was the prevalence of strangulation and how much resources they turned us on to. The links are in the show notes on the website, but there was and it's escaping me right this second, but the
Strangulation
Institute. I was going to say project, but just the amount of information that was there specific to EMS, but.
Yeah.
You speak to that a little bit, because that was wild. That wasn't something that I had totally wrapped my head around.
So on the EMS, on that site, something I think is really cool, it has a video, because a lot of people that are victims of domestic violence, they're not going to leave. They're scared to leave still. They're not at that point. They're not that 7th horrible assault. They're not there yet. So but you see they've got visible marks. They're kind of like foggy-headed. and they're not going to leave with you. That there's a Strangulation Institute video where the EMS guys are like, asking about vision, asking about hearing, and then talking about the lethality of strangulation. Just a brief little point of how watch for, if you can't swallow your own saliva, if your voice gets more hoarse, if your vision gets worse, if your ears get if you have these changes, call 911.
Right.
And it's like the lethality, it's so deadly, and for them not to come to the hospital when they are having those symptoms is scary.
Yeah, and the reason why strangulation is such a hot topic and a big deal is because in the last April in the state of Ohio, strangulation became a felony crime. So a felonious assault, which as mandated reporters, we now have to report when a strangulation has occurred. And so that's what makes it relevant for us. And then statistically speaking, someone that has been strangled just one time is 10 times more likely to die by that by the hands of the perpetrator. Yeah. So that's why law enforcement and the legal system is, also concerned about strangulation injuries that occur because of, it's a predictor for future fatality.
80% of cop killers have a reported history of strangulation.
Right. That's
That's reported. The other 20% might have strangled people, just never got reported.
Wow, that's nuts.
Because because people strangle, other people, because it's, they want to show you, like, I can so easily kill you with my bare hands. It doesn't take anything for me to just choke you to death, right? Strangle you to death in a matter of minutes. And it's such a hot tool for enforcing that power and control over somebody. So it has significant implications.
Did I tell you about that case? Were we talking about that case that I was on a couple weeks ago?
Yeah.
That's that statistic puts that case into just a wow. That's.
And I just think it's good to talk about it and bring it more to light. The more people that watch this and the more people that hear it are going to be able to go to our website, watch the video, and just get more education out there, because it's not something that we commonly think about. We see it as an assault, we treat the patient, but it's once you see and hear more of the statistics and see how it could just lead to be more fatal and statistically is going to be fatal, I think it brings more to light. So I think the more education that comes out with that, then the better prepared we can be to treat that patient and hopefully get them out of that situation before it's lethal, or maybe before that 7th time.
Right.
Statistically.
Yeah, no, that's exactly it. Even victims don't, it's just such, it's such a common occurrence. It's like part of their assault. Like, to them, they don't even realize, like, the lethality of it or how dangerous it is to occur. And so, just like you said, getting that education piece out there is really important.
Go ahead.
Oh, and strangulation is something else that, because of the trauma, they may not have their thoughts, organized yet. They may tell you guys they were strangled, and they get to the hospital and not tell the doctor.
Yeah.
Like, that's the important thing to relay.
Yeah, we've never experienced that ever before. Never once. So, we got another question in-house here, and we've got another question from Facebook here. So take it away, my man.
So we keep talking patient care comes first. We all know the state of the hospitals nowadays, taking people to triage and stuff like that. Are these cases where, let's say UH Portage, we let them know on the phone before we say we might need a SANE nurse? Is this something where, I know like trust is huge in situations like this, is this something where this patient's gonna get like a priority room in the ED? Or like, do you take the risk of like destroying the trust by putting them in triage and making them sit and wait? Or like something where we could advocate for maybe waiting on the wall for an extra 10 minutes until this patient gets a room, that way they have someone to talk to in
That would
this
be
type
awesome.
of situation.
I love that question.
That's awesome.
Yeah, that's really good.
So we triage people that report domestic violence assault and sexual assault as a 2. That's the same as a chest pain. So we don't want to put them in triage. So your point of putting them up against the wall and like kind of talking to them as they get a bed is awesome. To they get a little private room. That's really nice. I mean,
Yeah.
that's ideal.
Standard of care, they're level 2, triage codes. Unfortunately, we know the state of healthcare right now, and we try our best to get them into a private room and prioritize their care. That's standard of care.
All right, from the Facebook, are there still resources, and this is from Josh, thanks for typing this in, Josh, are there still resources offered by the SANE nurses if the patient is outside of the rape kit timeline?
Excellent question. Yes. So they can have all of the testing done for the sexually transmitted infectious diseases, and then all the resources be provided. And of course, the medical be medically examined first.
Okay.
Yeah.
So yeah, still the resources available.
Yeah, absolutely.
So they can't get the evidence collected, right? Outside of that 96-hour window, but still all the other things can occur. So
Yeah, any other medical support we could offer, any other emotional support,
Yeah.
some of the
Yeah.
other mental health support you talked about as well.
yeah, safety discharge planning, follow-up care, connect
Okay.
them to community resources. Yeah.
All right, as we're getting kind of close to the hour here, does anybody else in the room have anything? Let me take one quick peek, make sure nobody snuck anything out in the interwebs. There was one simple patient advocacy take-home thing from the recorded episode was have them get another change of clothes because what they're in might be evidence. A simple thing is not sending them home in their clothes and not sending them home in a gown or scrubs or something. What does that take us? 2 minutes on scene, if that. But
And if they don't grab clothes, we have clothes.
of course, right. But
They just might be more comfortmore
of
in their
course,
clothes,
it's
essentially.
It's their
their
own.
clothes.
Right.
Yeah.
So.
Nothing
Yeah.
like your own.
All right, we've got one little more one more thing to do, and that is to figure out where we're going next.
Yeah.
So so first of all, thank you for anybody. There was about 5 of you that got on our website, clicked on the host the podcast, and have invited us to come. We've got those 5 people here that have. Suggested that we can come, and you get to tell us where we're going to wind up next.
You are going to.
We are going to
Madison Township.
and that is the Madison and Richland County. So Madison Township, we're gonna see you next month, and that is also with Dr. Spanner, I think, is their medical director.
Yes.
That's with Dr. Spanner, and that is field death, termination, and DOA topics. So
Great.
thank you all. Thank you both for coming.
Thank you.
Kent
Thanks for
Fire,
having us, guys.
Gentlemen, thank you.
Thank you,
Thank you all
guys.
for having us. And everybody have a great night.
Good night.